Yeah, thank you guys so much for inviting me. I'm glad we could get connected, and I'm glad I could be here today. Like Maya said, my name is Daniel Mead. I'm a clinical psychologist over in Maui, and wanted to kind of talk today about setting up or kind of the theory or the ideas behind integrated care and what that can look like in a primary care setting. It covers a very wide variety of things and a very kind of wide variety of possible services, all of which we could potentially use kind of to meet the needs of our patients. So to give you a little bit of background on myself, like Maya said, I am a licensed psychologist. I'm the integrated health director at Malami Ikeola, which is an FQHC over on Maui. So our department covers behavioral health, behavioral medicine, substance use, nutrition, and Dr. Stevens actually just joined us part-time as a consulting psychiatrist. So we've kind of been doing the integrated, different stages of integrated work since I've been here over the past 5 years. And it's kind of moved and shifted as we've seen the moves and needs in our community shift. And so kind of that's what I wanted to talk a little bit about today was kind of how integrated care can fit into lots of different types of primary care settings, again, all depending on kind of what the needs are. So wanted to talk kind of first about integrated care, why it's important, how it compares to what we consider kind of usual care, right? Which is kind of identifying a patient that needs services, referring them to another provider in another place, and how integrating care provides not only a different type of care, but generally a more effective type of care. Talk some about kind of different models of integrated care and the different degrees of integrated care that exist. Talk a little bit about how integrated care can look in a primary care setting. I'll look at two specific models, one being the primary care behavioral health model, which we've been kind of working and developing at Malama over the past 3.5 years or so, as well as the collaborative care model, which is kind of what I would call advanced primary care, kind of falls somewhere between traditional primary care and specialty care. And then I kind of at the end talk about kind of, again, some of the basic takeaways to remember about integrated care and kind of just review some of the major points. I'm going to throw a lot of information out at you guys today. I'm assuming these slides will get sent out, and I'll send out the most recent version of this to my guys at the end of this, so you guys can have that as reference. But I'm going to kind of give you a lot of information to chew on, and then if anyone has questions, we can ask at the end, or my email will be included. So happy to answer whatever questions you guys might have. First off, though, we're going to do these kind of pre-test questions just to set the stage and see where people are with things. A little bit is why, what's the purpose of integrated care? Why is integrated care important? Why are we talking about it? One of the reasons is a lot of the things that come up in adult also come up in pediatrics, which is access to care, a number of providers, number of specialty providers, all of those sorts of things. And if we put that kind of specifically in a Hawaii context, we can know that starting out just baseline, Hawaii doesn't necessarily have the best access to mental health care for adults, which makes the accessibility of care for pediatrics that much harder as well. The need doesn't necessarily change, but if we have a limited number of providers, if we have a limited number of resources, what's the best way that we can make sure the people who really need that care are getting to the resources that we have? And also, how can we make sure we're using those resources in the best, most efficient way possible so we can make sure the most people possible can access those resources. Looking at Maui, when we were doing some of our research as well, a lot of the concerns that came up from the community health needs assessment that Kaiser did when they took over the hospital here, identified a lot of things that overlap with not only kind of community mental health, but were also more specific about youth mental health as well. which was kind of the general lack of services, social support, which you can imagine during COVID has gone down even more. The idea of kind of disconnected youth, and then the risk of suicide, which in Maui has not been going up, but I know on some of the neighbor islands has really been a significant increase and a significant topic because it's been much more common. A lot of times, or a lot of the ways that Hawaii is experiencing youth mental health are reflected in kind of the national statistics as well. So if we look kind of nationally, and this is from 2021, so pretty recently, they found of school-age children, 20% had some kind of mental, emotional development or behavioral diagnosis or disorder. So it's a significant number of kids are having some sort of behavioral health need. 1 in 3 high schoolers were reporting kind of symptoms of depression, kind of low mood, hopelessness, feeling sad kind of over time. And 16% of high schoolers had actually made a suicide plan in the previous 12 months. So kind of, a significant number of kids, if we are, think about just the number of patients that we might see in a given week or a given year, this kind of comes out to a lot of need, even if we're not necessarily seeing it. And then kind of going back to, if this is the situation, the bigger problem also becomes only 10% of those high schoolers were actually receiving treatment. So no surprise here, the need is far outweighing the availability of resources or the ability to connect people with resources. When we look at Hawaii, kind of, again, more specifically, and look at some of those numbers that tend to kind of, some of the things that tend to pop up in the pediatric population, we see, again, some pretty high numbers of things that we would want to address, we would want to make better. Things that go from kind of, what's a child's or what's a patient's social connection, social interaction. Here 17% experience some level of bullying on property, so that doesn't even count what goes on online. We again see kind of 14, almost 15, kind of 15-ish% had experienced a major depressive episode in the year prior, and almost a quarter of high schoolers were not getting 8 hours of sleep a night on school nights. So all of these things, I think we could pretty easily say as healthcare providers, these are going to have significant impacts on kids' health, right? Physical health, emotional health, mental health. And as healthcare providers, what is it that we're able to do here, right? How do we address this mix of environmental, mood, physical factors, all of which are going to contribute not only to health outcomes currently, right, but also that are setting up kind of adult health for a lot of these patients? And what is that going to look like for them? How can we kind of address some of these things now preventively so that they don't become larger problems in the future? We also already see a lot of kids that are coming in with some sort of behavioral health, either question, diagnosis, problem, a lot of times identified by the parents or the teachers. And primary care tends to be the first place that people show up when something's going wrong with their health, right? They go see their PCP and say, here's what's going on, what do we do here, right? Most of my experience is in adult medicine. And I certainly know that what adult primary care providers are asked to do in a 20-minute visit far exceeds not only what the limits of time space allow, but especially when it comes to behavioral health, a lot of times exceeds the limits of what they were trained on. 2 weeks or even a month of a psychiatry clerkship 15 or 20 years ago is not necessarily setting you up for prescribing medications for someone who's showing symptoms of psychosis now. And pediatrics falls into that even more, because so many behavioral health concerns tend to show up more in childhood, tend to be identified by the schools, by the parents, and then someone's in your office going, hey, what do we do? ADHD, I think, is a great example of that. So kind of looking at this, the symptoms of trauma, the symptoms of stress, and the symptoms of ADHD there are some things that are kind of unique to both of those diagnoses, and then there's a lot that overlap. And so someone comes in and says, hey, I think my kid has ADHD, and they're talking about they can't sit still, they're distracted, their grades aren't good, they're not sleeping well. And as a primary care provider, you're like, okay, well, I guess this could be ADHD. It checks those boxes, but this could also be trauma, and it checks all those boxes. And how do I differentiate between these two? Because if I give a kid with an anxiety disorder a stimulant, that's probably not going to go super well, right? But what if it's more complicated than that even, right? If we just look at these overlapping symptoms, right? Concentration, distraction, not sitting still, we're not only saying, could this be environmental? Could this be neurological? We would also have to say, like, what if this is some sort of substance use? Or is this a primary sleep disorder that's causing the attention and the learning issues? What if it's a metabolic issue that's sort of systemically causing, kind of some of these physical symptoms? Maybe they don't have ADHD, but maybe they have some other kind of learning disability. Is this like a language processing thing? Could they have a hearing loss? Like, what if this is just purely situational? Are their parents going through a divorce? Did they just move to Maui? Are they in the middle of a global pandemic, perhaps, that might be affecting their mental health? And so you're sitting here in the primary care office, right, with all of this information and all of these possibilities going, I'm a pediatrician. How am I supposed to figure this out, right? And a lot of times, the way you figure that out is you send them to someone in behavioral health, right? You send them to essentially a specialist and say, hey, help me figure out what's going on. Just like we do with most other medical subspecialties, right? But again, if we go back to there are very few providers and there's a lot of need, how do we use those resources as best that we can, right? The question essentially is, how do we increase access to behavioral health care as a whole? And part of integrated care is saying, well, what if we didn't use specialty care as much? What if we could do more of this in primary care where people already have access, where they already have established relationships with their providers, where they're already coming and asking for help, and treating some of this there? A lot of that looks like kind of shifting from the idea of one-on-one behavioral health care to looking at behavioral health more from a population health approach. So traditionally, when we think of behavioral health, we think of that sort of one-on-one individual care. They go for once a week for an hour. The provider meets with that one patient. They do their thing. They come back the next week, and kind of goes on like that. And that's really useful and that's really necessary for a lot of people. But as you can imagine, that really limits the number of people that one provider can see if the only care that I'm really doing is this sort of more intensive one-on-one care, kind of patient after patient every week. It fills up my caseload very quickly. And so if we start to conceptualize behavioral health not just as this one-to-one idea, but if we start to look at it more as a population health and say, what are we doing? What can we do from a preventive point of view, right? What can we do kind of on the sub-diagnostic level? Maybe they don't need a specialist per se, but they'd still benefit from something, right? Primary care is kind of the perfect example of this, right? Primary care operates on a population health level. It says most people don't need to see a specialist, right? If I have strep throat, I don't need to see an infectious disease physician. Primary care can take care of that, right? Behavioral health, we can think of as the same way, right? Just because someone has a behavioral health need doesn't mean they need to see a specialist. So what if we started taking care not only of things more in the primary care setting, but what if we started looking at how can we prevent? How can we target people who might benefit from some kind of intervention that would prevent them from needing to see a specialist in the future? And so how do we incorporate more of this treatment, more of these ideas, more of this kind of healthcare into the existing healthcare system and the existing healthcare that we're providing? So the integrated health model is really based in the biopsychosocial model, which was developed, kind of started to be developed back in the late 60s, early 70s, and now seems very obvious, right? Your biology and your psychology are interconnected and they're affected by the environment that you're in, right? That's kind of pretty basic now. However, 50 years ago, this was a little bit groundbreaking, right? This actually came up in the context of the social justice movement when people were starting to look at segregated neighborhoods and how to kind of integrate communities back together and saying, hey, why do some communities suffer a lot more than other communities, even when some of these factors are the same? Well, if you're in a neighborhood with high crime, low food access, poor air quality, that's going to affect your health. And kind of people started to kind of connect these things and actually started studying a lot more of these things to see how all of these physical and psychological and environmental factors fit together and affected each other. To give this state a little bit of context, post-traumatic stress disorder, right, which we now see, kind of think of, and we talk about trauma-informed care and all of these concepts. Post-traumatic stress disorder didn't become an official diagnosis until 1972. So the idea that past experiences of, kind of affected your physical and mental health even kind of later on in life was just getting into kind of the books and just becoming a more official thing kind of around the time that this model was being developed. So it was sort of all happening at the same time. And as that kind of concept was taught more and studied more and used more, we've continued to sort of see, oh, hey, look at all the different ways that this starts to kind of the ways that things interact that we never even realized. The other reason that integrated care is really important is because the primary care system is kind of the mental health system already. Again, most people, at least in adult medicine, most people get their psychiatric medication from their primary care provider. I think it's about 60% of people, get some sort of psychotropic from their primary care provider, not from a psychiatrist or a psychiatric nurse practitioner. So this is where the patients already are, right? We're already seeing these patients. They're already here. It makes a little bit more sense to treat them where they are, where they're asking for help, than to try to get them to another place and kind of put more steps or potentially more barriers between the patient and their care. We also know that most referrals in adult and in pediatrics tend not to actually happen. People don't show up, or they show up for that first session and that's it. There's a lot of different reasons for that. Some of that is the stigma that comes along with mental health and with seeing a mental health provider, or going to the mental health center, right, or similar. It's a new place, it's a different place, it's a different provider, and people are a little reluctant, right? Especially if they're having to go in and talk about all their business. They might not want to do that. And so people tend to kind of not follow through on those referrals, which generally means they end up back in the primary care provider's office. And then patient preference, right? A lot of times patients come to see their primary care provider because they know their primary care provider, they trust their primary care provider knows them. So if we go back to this idea that your mental health, your physical health, all of these things interact, a lot of times the person who's best suited to do a lot of these interventions or to start initiating treatment is the primary care provider, because they know the patient the best. And so we can use that relationship, we can use that existing knowledge that the primary care provider has to get a better understanding of what's going on with the patient and therefore provide better, more effective treatment. We also know that there's a high level of psychiatric and medical comorbidities. That's especially true in adult patients, but in peds as well. A lot of people that are having a lot of physical or somatic symptoms may also be having a lot of anxiety or other things going on. So again, it's already in the office. You're already having to kind of treat both, even if you don't realize it. What if we could just do that better? And then we also want to, again, look at the implications here for, when these things are showing up. When is it trauma, or is it ADHD, or is it learning disability? Like all of these things, what if we could get a better diagnosis right off the bat? What if we could get a better treatment plan going that was more effective, that people stuck with more easily? What if we could refer fewer people out to those very limited resources because we had a better understanding of what was in front of us, and we realized, oh, hey, we can actually do a lot right here in primary care first and see if they do really need a specialist. So it kind of hits on all of these different levels, not only from the patient side, but also from the provider standpoint, and then also from kind of a systems and healthcare systems utilization standpoint. So I've used this term integrated care 100 times now. What exactly is it that I'm talking about? What is integrated care kind of when we really look at it? Integrated care can, again, look like a lot of things, right? It's a kind of a big umbrella term. It just means we're addressing physical and mental health or physical and behavioral health at the same time. And so this can kind of be, I think, a helpful quadrant or a helpful graph to sort of understand how behavioral health and physical health, again, are already showing up in the same places. When we think about traditional behavioral health, we're kind of thinking of that, a lot of times, that quadrant 2, right, square that's kind of in the upper left corner. There's a high behavioral health need and generally a lower physical health need, right? And so that's where we see things like specialty mental health, therapists, psychologists, counselors, those sorts of things, referrals to psychiatry, inpatient psychiatry, where the focus really is just on the mental health aspect, right? And then we do a lot of sort of the physical health stuff, which is that lower right quadrant, which is, inpatient medicine, cancers, major surgeries, things like that. And then sometimes we see the sort of high behavioral health, high physical health part where there's sort of a lot of both going on, which could be inpatient medicine or psychiatry, but we see a lot too with like hospice, end of life things, the emergency department, people coming in with either a primary psychiatric issue or a primary medical issue that, obviously is affecting how they're feeling in that moment. And what we don't kind of think about or see as much is what's down here in quadrant 1, right? Which is where there's a lower behavioral health severity and a lower physical health need, but there's still some of each, right? And this is where integrated primary care can really, again, take a much larger role. Because if we think of this from a purely physical health standpoint, right, most patients get their care in primary care because most patients only need primary care. And so behavioral health can fit into that as well, because there's a lot of people that have a behavioral health need, but may not have a super high behavioral health need. And this is where, integrated primary care fits, very pretty well and is able to be managed in primary care because you're not talking about a high need, high risk behavioral health thing going on. You're talking about a behavioral health need that is kind of, maybe mild to moderate that would benefit from intervention, but again, doesn't kind of get to the level of needing specialty care.
Are we frozen?
I was just wondering the same.
I was like, oh, I hope it's not like battery crapping out or anything. Wonder if
No, it's not us. I think maybe
Dr. Need froze, huh?
Daniel might have had a connection problem. I'm assuming he'll be back in a moment.
There he is. He looks like he's back.
Yay!
In movement.
Great. That was quick.
Okay, let me. Oh, there. He's still co-host. Okay. Hi, Dr.
Right.
Mead. I think you cut out for about a minute or so. I don't know if you were maybe talking or presenting to yourself for 30 seconds.
There we go. Sorry, the Zoom screen is behind the PowerPoint screen, so I can't see both, unfortunately.
That's okay.
Was I on this slide already?
I think you'll have to reshare, please.
Okay.
And you were just on the slide with the 4 quadrants. You were talking about the lower left one with the lower acuity, and then after that, we didn't hear much.
Gotcha. We were there, yeah?
Yeah,
Perfect.
exactly.
All right. Yeah, so just kind of to go back quick, this sort of lower behavioral health need, lower physical health need is exactly what primary care is, right? If we think of it from kind of just the medical side, primary care is that, someone has a need, but it's something that doesn't require, a specialist or hospitalization. It's sort of that place where most people get their care because most people have something go on, but it's not something super severe. And we can think of behavioral health as being the same way, right? People have behavioral health needs all the time, but it doesn't always require the level of care that a specialist would need to take care of. And therefore, we can address a lot of those things in the primary care setting. So primary care as sort of like a more formal definition, we can think of as sort of the medical team and the behavioral health team or behavioral health provider working in tandem or working together in some way. And again, there are different iterations of what this can look like. But the idea is that instead of sort of the traditional primary care specialist model that we generally use with medical specialties and behavioral health, where we kind of have two different providers doing two different things and maybe communicating back and forth. This is a much more sort of systemic working together, exchanging of information, treating kind of the patient as a whole at once, as one team. And so we're looking at sort of this whole-centered approach that therefore is going to take into account not only the traditional kind of mental health, mood, substance use things that we would think of when we think of kind of traditional behavioral health, but we're also going to think about, health behaviors, right? Diet, exercise, sleep hygiene, stress management, study skills, parenting skills. We're going to think about how are people managing, or how are patients managing life stressors, right? Moves, changes of schools, divorces, new siblings, the general normal things that happen in life that are probably going to have an impact on how they're feeling or how they're functioning. We can provide that support. We can look at the somatic, the physical manifestations of stress. So headaches, stomach aches, the things that tend to, not be maybe a traditional symptom of anxiety that we would think about, like the excessive worrying or things, but that are more physical, but still would need to be treated behaviorally. And then also kind of go back to how are patients using the healthcare system? How are we educating and empowering patients to be able to self-manage better, or identify resources better, that they're not dependent on coming to their primary care provider for everything or going to the ED for everything. We want them to be able to use the healthcare system in the best way possible, because that gives them the best care possible. So this is sort of a little bit of where we start to see a difference between kind of specialty behavioral health and that kind of traditional model. And we start to see the sort of primary care behavioral health, or the integrated behavioral health, where we're not just looking at mood and substance use, but we're also starting to look at medical disorders and physical symptoms and disease management and kind of that overlap. So again, kind of this idea of primary care integration existing on a continuum, we can see kind of it can go from a very minimal amount of connection and collaboration to what we would consider kind of full integration or full collaboration. So if we go kind of over to the left in the blue on level 1, minimal collaboration, this is our kind of the traditional way that behavioral health has generally been provided to patients. It's that siloed care, right? Medicine is here, behavioral health is here, substance use is here. It's 3 different providers with 3 different medical records, 3 different schedules, 3 different treatment plans. Maybe they talk to each other, but you're really talking about kind of splitting a patient's care among different providers doing different things who all have different specialties. As we start to get kind of towards the middle, there might be sort of more formal collaborations, business agreements. Maybe there's an official kind of referral workflow that gets patients, from one provider to the other provider in a more systemic, guided way, but still looking at really 2 different providers doing 2 different things, treating 2 different sets of diagnoses. As we get into level 3 and 4, we start to see kind of some more of this tandem treatment. We tend to see where the behavioral health and the medical services are on site, kind of maybe in the same building or on the same floor, maybe in the same office, but tend to still have kind of separate treatment plans, keeping separate schedules. They'll be sharing an EMR. There might be some kind of informal or kind of communication to help with referrals. And if I can see the EMR, kind of the medical stuff, that gives me a better background to know what the patient needs are, what's coming in. So there's kind of more of this exchange of information,
Oh no, it's frozen again. Let's see.
Provider and be scheduled with
Okay.
behavioral health at the same time.
Sorry, can you repeat maybe like the last 20 seconds or so, because we couldn't hear you.
Yeah, sorry, that
Yeah.
one popped up.
Yeah, so sorry about that.
No worries. I was saying kind of the middle part is where you start to see more of, instead of kind of being in parallel, the systems are sort of overlapping a little bit more, but they're still pretty separate systems. So there's still separate schedules, you're still doing separate treatment plans, you're still treating kind of different diagnoses, but there's kind of more overlay of perhaps being in the same office, sharing the same EMR, kind of having a more formal relationship between the medical and the behavioral health providers. And then as we get into the far right, the kind of more closer collaboration, this is where we start to see, instead of having two systems that overlap, we start to see two systems that start to merge. So you start to see shared scheduling, you start to see shared treatment plans. You might see co-visits. We do this in adult a lot of times where the medical provider will come in and talk about, hypertension, med management, those sorts of things. And then behavioral health comes in and talks about, hey, last time we were talking about how you're managing your stress and making some diet changes, and how did that go and what got in the way. We start to really see where everyone's starting to treat the same set of diagnoses. Everyone's working off the same treatment plan. Everyone's really kind of treating the same patient for the same things for whatever it is they walked in the door with. And so that's kind of the more far end of kind of full integration. I've seen full integration clinics where the behavioral health person doesn't even have their own schedule. They just see every person that comes in with the primary care provider, because pretty much everyone has some sort of behavioral health needs. So even if it's like a 10-minute check-in, they just have the same schedule the medical provider has, because there's almost always something that from a behavioral health standpoint that can be improved or addressed with every medical visit. So again, integrated health can, it covers all of these different things. And a lot of that's going to depend on kind of what your resources are, what your needs are as a clinic, kind of what maybe limitations are of training or what providers are available. But again, it can look like all of these different things, which is kind of the cool thing about integrated care, because there's something that generally will fit for whatever the patient has a need for. And I think this is a kind of a good example too of remembering that there are definitely things that medical providers do, right, that medicine does, and there are definitely things that behavioral health providers do, and things that are unique to each of those. And there's also a lot of overlap. So there's a lot of work that we're both already doing. So this sometimes for especially medical providers can feel very like, oh, I don't know about the behavioral health thing. This feels a little scary. But you're really using a lot of the skills that you would need already, and you're really doing a lot of that kind of work already. We're just asking you to do it with a different diagnosis, really, or to ask different questions. But everyone's used to doing screens, everyone's used to doing HPIs, everyone's used to tracking treatment outcomes. This is all kind of the same stuff. We're just kind of looking at tracking a different type of diagnosis. And if we look at the research outcomes, this isn't just sort of like a nice thing that feels good. We do actually see that the research shows that the outcomes for this are better for patients and for providers. So satisfaction is better. Again, the healthcare utilization is better. There's generally a reduction in crisis calls, emergency department visits, because patients are being kind of managed better and empowered and given the skills that they need in primary care to keep them out of the ED. We also, again, kind of see improved access to care. Functioning improves a lot of times because we're focused a little bit more on functioning than we are on treating a diagnosis per se. And symptom improvement, right? And that covers everything from your traditional mood things like depression, anxiety, also the overlays that come with a lot of the things that we experience in life. How's your sleep? How's your energy? How's your concentration? Are you moving your body every day? All of those sorts of things, again, because they're being addressed in a way that's accessible to the patient in a place where the patient already is. And I know a lot of admin people kind of always like this part too, which is, am I back?
You're fine.
Okay, I got a
Yeah.
little pop-up that said my internet was unstable.
Oh, no, I think you're okay.
Cool. So a lot of these things also dovetail with, our UDS measures, with the primary care medical home model and certifications, with the quadruple aim. These are all things that we're already working on and trying to do and wanting to do. And this is just kind of dovetailing with all of those things. So it slots really well right into a lot of the work that we're already doing in primary care. This is just a different and a newer way to do it, to address some of the things that we do struggle a little bit more with in the primary care setting. This is also kind of one of the big studies that was done. This looked at depression remission over a 12-month period back in 2002. This was also in adults, but this was sort of what was called the impact study. And this was kind of one of the major groundbreaking studies that looked at integrated care. And what they found, you can see in the blue, they gave kind of care as usual for people who met diagnostic criteria for depression. Care as usual being medication and a referral to some sort of behavioral health provider. In the orange, which they call the collaborative care model, which I'll talk about here in a couple minutes, that was the amount of people who had depression remission at 12 months, who had this sort of primary care model of behavioral health. And it's pretty easy to see which one worked better. So kind of the idea that integrated care is maybe this sort of nice thing that would be like a perk. It's really starting to look like this might be more of a necessity. And the research, again, this is from almost, I guess, 20 years ago now. But the research that's come after this has really said the same things over and over again, which was that care as usual, even co-located care as usual, where you had someone that was in the office that just you referred your patients to that behavioral health person that was in the office to do care as usual. The effects are much lower than having a kind of a more integrated, coordinated type of care for behavioral health, people's behavioral health needs. So how does behavioral health
Can
work?
I just do a quick time check? We have about 15 minutes left.
Yes.
Okay,
Yeah.
thanks.
So how does this work? I'm going to give kind of two examples of what this can look like. So if we look at Molly, 12-year-old girl who presents in the office, history of headaches and stomach aches for about the past 8 months. She's got some sleep disruption, school disruption, says that she feels like crying all the time. Her mom says she's fine. She's just being spoiled because her dad and her grandparents let her get away with everything, right? So this is something that you might kind of recognize as being things that you see in your office. If we look at kind of, again, doing that biopsychosocial assessment, we're going to look at a lot of different factors that may be influencing how she's doing, how she's feeling, how she's functioning. And then we're going to also, again, kind of do the medical side of things and look at the things that may be indicating that this could be of a more physical and medical cause for some of these symptoms. But just from the presentation, we don't really know, which is which at this point, right? So one of the models that we can look at is one of the more integrated models, which is called the primary care behavioral health model. And this is the idea of treating behavioral health as primary care, right? So the idea of kind of whatever the PCP is treating is what the behavioral health person is treating. This is really kind of working right alongside with the medical providers in the pods, doing the same, kind of 15 to 20, maybe 30-minute sessions in the exam room to help either clarify diagnosis, maybe give some, some possible interventions to see if we can improve symptoms and functioning, and then reporting, back to the PCP for follow-up and see what may be necessary. Addressing the same things that a primary care provider would address, right? So we're still looking at kind of mood and affective concerns, but maybe not severe, more severe presentations, physical illnesses, health behavior changes, school and family challenges, as well as kind of health prevention, shots, safe sex, substance use, all that good stuff. I'll skip over this just for the essence of time. But this is kind of a quick and dirty comparison to see how that model compares with sort of your traditional mental health model. The main things that look different are working in the same office, in the same exam room, using the same chart, having shorter visits. And instead of functioning on kind of the resolution of a mental health concern, looking at how do we improve function? How do we help you kind of feel better? Is this something that is a mental health diagnosis, or is this something that we can kind of address here in the office that may just kind of be what life is throwing at you right now, and let's see if we can make that better. So this would be kind of, as a primary care behavioral health consultant, these are the kind of the things that I would look at in that first session, which is, is this stress related? Is this anxiety? What's going on at home? What's going on in life? Maybe Molly just started her period 8 months ago and she's freaking out. Maybe her parents are fighting a lot. Maybe she just moved schools, But if all of that's going on, how can we give her the skills that she needs to be able to manage that better? We could talk about sleep hygiene, right? Is how much is sleep contributing to some of the emotional lability and schoolwork issues? And then again, ask about kind of what environment's going on, how's school, how are your friends, what kind of connections do you have with people? Talk about some skills, talk about some things you can practice, follow up in 2 weeks, see what was better, what was worse, and see if there may be a need for referral at that point, or if we can kind of get some more information if things didn't get better and kind of go from there. The other model that we use a lot is called the collaborative care model. This is kind of what we would almost call like an advanced primary care, where you have a consulting psychiatrist who works kind of indirectly with the primary care provider and the patient, but coordinates mostly with like a behavioral health care manager or behavioral health provider. And the behavioral health provider provides a lot of that direct service, does symptom tracking, treatment planning, goes back and forth with the psychiatrist and the primary care provider as far as if there's, if symptoms are improving, do we need to try a different medication or different dosing? The goal of this, this model is that instead of the psychiatrist doing one-to-one visits, you can have a psychiatrist who can consult on perhaps 50 patients in a week, instead of, maybe only seeing 20 patients in a week. And so going back to this idea of access, we can use the psychiatrist and the primary care provider as the predominant medical providers, and then add in sort of the behavioral health support, because again, the patient knows their primary care provider, and if the primary care provider can provide a lot of that direct service, that's a lot of times what keeps the patient most engaged. And so this is sort of, again, a different configuration of incorporating primary care and behavioral health together, but also for something that may be, again, a little bit more intense than kind of your garden variety thing, but may not need that referral to specialty care that might be able to be managed in primary care with some additional support from a psychiatrist. This is kind of going through that model in a little bit more in detail, which again, I'm going to just skip over because of time, and what that might look like as far as the different roles of what people could look like in that model, and kind of get down. We've got 10 minutes left. Get down kind of to the takeaways, and what are the things to remember in all of the information that I threw at you. I think the most important to remember is that primary care is primary care. We're not talking about adding necessarily specialty care in or taking on a level of patient that requires specialty care. Most people benefit from some sort of primary care intervention, and therefore there's a lot that we can do in primary care to help people to improve their health, to give them the information and the support and the care that they need. the patients are already in primary care. They're already in front of you. So we want to, help them where they are and help them when they're where they're at, because they're already here. We also kind of want to remember, going back to primary care, is primary care. We don't necessarily need to pathologize normal life. If someone's parents are splitting up or they just switch schools, that's a normal stressor. Kids are going to have a normal stress reaction to that. We don't want to kind of stigmatize and say, oh, we need to get you a behavioral health person because you're not happy your parents are getting divorced. We can address those things and talk about those things and say, yeah, this is a normal part of life. It's really hard sometimes. And what can we do to help you get through that? And then to also remember, integration exists, on this continuum. So integration can look like lots of different things. It just depends on kind of what the needs are for your clinic, for your patients, and then figuring out how to kind of design a program that works and makes sense to meet that need. And then the last bit, which again, I think is the big shift in talking about integrative health, is going from this idea of one-to-one care and shifting to the idea of providing kind of a population health model, right? We're looking at making small changes in a lot of people, right? As opposed to trying to make big changes in people that might have more significant presentations. And again, this is what we're already doing in primary care medicine, right? We're already operating at a population health level. We're just going to think about doing the behavioral health kind of in the same way. So enough from me. We'll get back and do these review questions and then open up the floor.
Okay, I'm going to launch the poll. Okay, I'll give everyone about 30 seconds or so to put your answers in before we review the answers.
So while everyone is finishing up the poll, I want to just throw something out as a question I think a lot of our participants may have that we can talk about after going over the question answers, which is practical aspects, like how would our pediatricians who are on this call or others, that we have a couple mental health psychiatrists, and I'm not sure if there are any psychologists or other mental health professionals here too, how would we actually make that happen? But first, I'll let you go over the question answers.
Okay, sure. I'm going to close the poll now.
Okay. Can everyone see what the answers are, like what the results were? I don't know what it's on their end.
I think if you want to, I X'd it out. Did you want to try? You can say show answers possibly on your end since you're a co-host.
Oh, okay.
Like publish the poll results. Let's see if I can do it on my end too.
Share results?
There we go. Okay,
gotcha.
I'm sharing mine.
Gotcha. So if we talk about the least integrated type of care, again, these are all integrated care models, but the majority got it right. The co-located model is probably the least integrated, because really what you're saying is that both people are in the same place, but you're not necessarily saying that they're sharing EMR, they're sharing treatment plans, or they're necessarily working in collaboration. You're really just kind of saying that they're located in the same location. How does primary care model address health? Again, the majority got it right. By focusing on community and population health, right? That's the big shift in going from traditional mental health to primary care behavioral health, is kind of not focusing on the one-to-one, getting people scheduled for behavioral health appointments and those follow-ups, but saying, again, how can we touch kind of the largest number of people that we can? And a lot of times that's by not taking on the people who have the biggest need, but helping the most people that we can who might have a more mild to moderate need, and being able to see 10 or 12 people in a day instead of kind of the traditional 6 people in a day that a traditional behavioral health person might see. And then integrated health or integrated care models primarily focus on addressing comorbid mental illnesses that present in primary care. This one is actually false. The idea of primary care behavioral health is that we're not focusing on mental illness, we're focusing on what the patient need is. So if the patient need is managing their diabetes better because they're not taking their insulin correctly or they're not changing their diet, then that's what we focus on. If we're talking about grief, then we're talking about grief. If we're talking about I can't sleep well, maybe that's because of stress. Maybe that's because of all kinds of things. You'd be surprised how many people come up positive for depression. And when I ask them based on kind of looking at them in front of me and go, anyone ever tell you that you snore? Oh yeah, my wife's like, I wake her up at night, I snore so much. And the question then kind of was like, all right, so do you have depression or do you have obstructive sleep apnea? Because that would explain a lot of these symptoms. And so again, that's kind of the big shift with primary care behavioral health, is that we're not focused just on mental health. We're focused on that whole patient, whole person care, some of it which will be mental health and behavioral health, but some of which will also be, managing physical health as well.